morning, everyone. We're going to get started knowing that there will be people coming in as we go, but at least we can do the introduction part. My name is Jeff Roscoe. I think most of you know me. I'm a pediatrician and Associate Director of the Mailman Center. And we have a Mailman Center Grand Rounds. And in the September and October Grand Rounds, we try to choose a topic that's of interest to the entire Department of Pediatrics. And so that's what we have this September date. And in October, we're going to have Don Bailey coming from the Research Triangle in North Carolina to talk about Fragile X and newborn screening. We also have grand rounds throughout the spring, but they tend to be more narrow topics focused on Mailman Center child development issues, to which Department of Pediatrics folks are always invited. So to sort of introduce today's topic, I want to ask you we're going to do a little interactive thing. Raise your hands if you are interested in improving the health and well-being of children. Okay, if you're not, why aren't you raising your hand? Everybody has to raise their hand to this or you have to leave, okay? How many of you believe that the environment where you live, where you work, where you go to school, and your family is like, has a large impact on your health and well-being of children? Excellent, so we're done, we actually good. How many of you think it's the responsibility of clinicians, that is people who see individual patients, clients, students, to think about those population health problems? See a couple people. There's a lot of debate, right? So, for example, a couple of years ago, one of the large health insurers came to our pediatric practice and said, we have some new metrics by which your pay will be judged. And the very first one was oral health visit. They said, no problem. We refer all the kids to see a dentist every year. And they said, no. You're going to get paid because they actually have gone to see the dentist. And you have to see the room with the five of us there. And it was like Elizabeth Kubler-Ross's stages of grief, and it was just horrible. Like shame, denial. We're not responsible for what a family really does. And in fact, the way the healthcare system is moving is not just we're responsible for patients doing what they need to do, get their medicine, go to the follow-up appointments, but actually their health outcomes. So is a 5-year-old ready to start school? Is a child fully immunized? Is someone graduating high school and having a transition plan? And imagine for a moment if our entire healthcare system was devoted to actually improving health and not just every time I see someone, we get paid. This is the way the healthcare system is moving around the United States. Florida is happening bit by bit. I met with the Medicaid folks about 2 months ago, and they are strongly in favor of a payment system that rewards us for outcomes and not just for incidental things that we do. To follow up on that, we decided at Mailman Center that we needed to better understand population health and the ways that environment and child health and well-being are connected. And we're very fortunate to be part of what's called the ULIN research team, and you're going to hear from all the members in a few minutes to talk about how we as an interdisciplinary team work together, think about how data is closely related to child health, and then implications for what we can then do for improving population health. The bios of each of the team members are going to be posted, so I don't have to go through the details, but I'll tell you that our fearless leader is Rebecca Shearer, and she's going to start us off. She's from the School of, she's a psychologist in the School of Education. We also have Christine Delgado, who is also a psychologist in psychology. She's in psychology. Scott Brown, who's an epidemiologist, and he is in public health. Our librarian is here, say hello. Vera Spike is here, but she's not speaking today. And we have half a dozen other folks who are part of our team, and I'm the pediatrician who's part of the team. So I will stop now, and I'll let Rebecca start and bring through the whole team. Please join me in welcoming the team.
Good morning. I'm gonna...
Closer to the speaker.
Okay.
Or close to you.
Good morning, everyone. My name is Rebecca Shearer. I am, as Jeff said, I'm a clinical psychologist and school psychologist by training, but have come to academia having been a practitioner in the field for many, many, many years. I was an infant toddler early intervention teacher. Then I worked as a developmental specialist in a NICU follow-up program for several years, and then I went back to school when I was older to get my Ph.D. And I've been working really as an applied psychologist and psychology researcher in early childhood settings for a really long time. So I'm really excited to be here. And as Jeff said, we are part of an interdisciplinary team that was funded to integrate lots of different pieces about children's environment and to look at them all together and explore different factors that might be important to children's development. So today we're going to try to do the best we can at highlighting different pieces of our work. Let's see. Figure out the technology. This is our wonderful team of all of our different members. Some of us are here today. You guys want to say? Some of us look younger. I'm going to do my best I'm new to the bifocal thing here, so I'm going to do the best I can and go back and forth. But we're child-centered, dynamic, and multidimensional, and many of you may be familiar with Bronfenbrenner's ecological model if you have a developmental background. And we think about our fields, how they work together. Each of us are coming from a different level of the environment and thinking about within the individual child and how these different contexts intersect to support children or to make life a little more challenging for children. So as just said, why are we here today? And these are the main points that we're going to cover this morning. The first point is where you live matters. And just curious, when you go to see children in a hospital setting or they come to see you in your office, do you ever think about where they're coming from? How many buses they had to take to get to your office? What is their house like? And where are they growing up? What types of environments do they walk through on a day-to-day basis? And what kind of resources do they have access to in their immediate environment? And where you live matters. For little kids, for little ones, their proximal environments, their most immediate environments, they're so dependent on those. And those resources in those early environments really shape opportunities present for those families and for those children in terms of setting the course for their life. And early childhood, especially birth to 3, you all know, is one of the most formative periods in early childhood. It's an opportunity when those little brain neurons are ready and they're out there and they're looking for stimulation and their little bodies are looking for nutrition and lots of experiences that will stimulate and support and form the foundation for their long-term life course. But at the same time, while they're the most malleable, they're also the most vulnerable. So it's really important for us to think about how we can then identify collectively through the use of population level data, how opportunities and risks in environments can be leveraged and looked at in the big like at a population level, to look at them to see how we could target areas that are in need of intervention. Okay, so that's what we're going to talk about today, and we hope that we can get all these little girls dirty and into it and excited about learning with lots of different resources in their school and their home environment. Okay. So why does place matter? It's complicated, right? So it's really hard to study this, and this is something that we are grappling with as a team. Environmental influences are really, sometimes they're very proximal, sometimes they're more distal, but they're varied. And there's lots of different types of environments that really influence children. There's social environments, so they're living in a family, in a community that's influenced by the family's finances, by the culture, and so on. But then there's also physical environments where, so Scott isn't more of an expert on that. The built environment, what are the buildings like? What are in that community? What are the green trees that are available and the parks that are available? The climate, the changing climate, all those different things are affecting children. And these factors interact in complex ways with individual level factors, risks, and protective factors within the child over time. So it makes it really difficult to study, and the influence changes over the life course. So some of these are more influential when babies are really little, some more as they grow older. And it's really difficult to measure, and this is something that we've been talking about on our team quite a bit. Because sometimes we're using individual level information that's aggregated for all, at population level, it's aggregated at geographic units like the census tract. And so the way, just for analysis, and sometimes that changes what you're actually measuring when you're looking at different relationships. And something we talk about a lot, just because you live in an impoverished environment doesn't mean it causes you to fail school or it causes you to be more sick or whatever. Causation is really difficult because there's so many different things that are happening, and you can't do an experiment to randomly assign a child to poverty or not, although there's some interesting studies out there that do some of that work. Looking at economic, you were mentioning the one about dental care. Okay, so that's why, and that's why it's difficult to measure. So why study poverty, and what is the societal problem here in Miami-Dade? Does this surprise you? That on average, over 30% of children under 5 live in poverty here in Miami-Dade County. Is that surprising to you? No. So that's higher than the national average. Welcome. And so, and unfortunately, children tend to, poverty is segregated here geographically, so, many children who are living in poverty live with higher concentrations of areas where other children are living in poverty, which is another added risk. But there's really a high cost to society and communities, and these are just we have an economist on our team, and she's helped us think about how to quantify the actual cost to society, to individual children over time because of not finishing high school, having poor health outcomes, and so on. And there are, like I was saying, there are disparities and inequities across the county in terms of access to opportunities, access to resources geographically, and to risks. And like I was saying, early childhood is an opportune time to intervene because we know that the earlier that you intervene, the higher rate of return on investment, the more opportunity you have to get those children on a positive life force. Okay, so that was sort of an introduction to what we're talking about, and I'm going to share with you just a brief example from my field and early childhood, child psychology, some work that we've done integrating data, early education data with the school district data and mapping it geographically in Miami-Dade. So I'm going to kick it off with that, and then I'm going to turn it over to Christine, and she's going to talk about her work and so on. And then we'll go to Robin and Scott. Okay, so I'm going to talk to you a little bit about school readiness. When we think about school readiness and developmental domains that help children get ready for school, what are some things that you think about? You all think about as pediatricians or future pediatricians? Shout them out. Don't be shy.
Behavior.
Behavior, thank you. Social emotional. Language. What else? Those are 2. Thinking about 5.
Toilet training.
What'd you say?
Toilet training.
Toilet training. So physical development and well-being. Okay. Some social emotional with the toilet training too. Okay, 3. So what else? Language. What about cognitive development? Problem solving. Okay. So we're going to talk about those 5 different areas now. This is a partner. I'm going to be sharing you findings and some data from a partnership that we've been developing over the past 5 to 10 years or so. It's called the Miami-Dade Ideas Consortium for Children, integrating data for effectiveness across systems. And it's a partnership, like I was saying, of all of the major early learning programs in the county. So you maybe, if you work with some of these different school systems or early learning programs, you may be familiar with some of the names of these programs. And these are the largest providers of publicly funded early learning programs, birth to 5 in the county. And this is how it works. This is how our integrated system works. Probably less interesting, but to you all. But basically, what it's showing on the left side are the blue boxes are the different partner agencies that we're working with, and then on the far left, and the yellow boxes are all the different data elements, which are comprised of lots of assessments, school readiness assessment, demographic information, information about their disability, any information about the schools they attended or the programs that they participated in for how many years, of what quality, and we're integrating them all at the University of Miami Center for Computational Sciences. And the idea is that through this data integration process, we are able to, through our relationships with the partner agencies, allow for them to ask interesting questions of the data that we can help then go back and analyze analyze the data and answer some of those questions that we can feed back to the agencies. They can use that information for policy decisions and to improve practices. So I'm going to share with you a snippet about one of the indicators that we've been working with and mapping geographically here in Miami-Dade. It's called the Early Development Instrument, and the idea behind this instrument is that kindergarten is a partnership between the Children's Trust, which funds a lot of programs here in Miami-Dade County, Early Childhood Programs, and the UCLA Center for Healthier Children, Families, and Communities. So kindergarten teachers in the early part of the spring fill this measure out on all the children in their classroom. They're mostly targeting, not all of the schools are participating, but most of the schools that are serving a high proportion of children who are getting free reduced lunch who are living in poverty. The teachers fill the measures out for them in those schools. Welcome. Jeff said that there'll be people tripling in, so we're coming. Okay, so this early development instrument comprised of 5 different developmental domains. And the idea behind this project is not necessarily to get individual assessments on individual children and monitor their progress over time, or look or screen for any disabilities or anything, or delays or anything like that. The idea behind this is for teachers at schools to fill in the measure and for the measure to be aggregated at census tract level, at the neighborhood level, either where the child attends school or where the child is living, and to be able to use that information to look at globally community needs and resources as it relates to children's development. So we have this information for several cohorts of children, and what we are doing is what I'm going to show you is what we've been doing to take a look at the larger picture and how we've been using it to understand needs from a developmental point of view here in the county. This is an overall average of the percentage of children that are considered on track in these 5 different developmental domains. You're considered on track if you're in the 25th percentile or higher on this measure according to national norms. So children tend to be doing pretty close to the national average in terms of physical health, but they're a little bit below the national average on these other areas of development. So at the same time now, we're looking and interested to see, well, does it make a difference? The type of community or neighborhood in which you live in, whether that relates to how developmentally on track or on target you may be, or at risk or vulnerable you may be. So we put together what's called it's an index. It's called a Child Raising Vulnerability Index, and it comes from the work of Charles Bruner. And it is an index of 10 census tract indicators that are social indicators, educational indicators, economic indicators, and wealth indicators. And you can see them here on the left side. There's 10 different indicators that come from the census tract, and they're linked to individual children's home addresses and school addresses. And what we look at is the count of vulnerabilities and attached to an individual child and to the census tract. And on the right, there's a table where listed at different sets of vulnerability counts. So at the top, you can see there's census tracts. 48% of census tracts have 0 vulnerabilities. But as you go higher, there are, thank goodness, less children that are exposed to more risk, but still a relatively high percentage of children living in census tracts where there's a high number of vulnerability risks. And you can see on the last column that it doesn't jump out at you, but that there's a higher percentage of children who are younger, birth to 4 overall, who are exposed to a greater number of risks in their census tract. So again, children are more vulnerable to living in poor households as well as poor census tracts, or more at-risk census tracts that may make them more vulnerable from a child development perspective. Okay, so just to show you how we put those two things together. So how do you think vulnerability in terms of neighborhood vulnerability relates to children's development? These are the 5 different developmental domains. The different shadings there are corresponding to the different number of vulnerabilities. So 0 is the gray, meaning the children are living in census tracts where there's no vulnerabilities or neighborhood vulnerabilities or risks. And then the darker is where, the darker blue is where 6 or more children are living in census tracts. Children are living in census tracts with the greatest number of vulnerabilities. And what do you see happening as children are living in census tracts where there's greater number of vulnerabilities? What is happening to their scores? They're going down quite a bit. So there's a negative correlation, or there's a negative relationship between the amount of vulnerabilities in children's neighborhoods that they're experiencing every day and their development in kindergarten. Okay, the last thing I wanted to show you is that we took this information and we mapped it geographically, and we put them side by side. This is a snapshot from one of the policy briefs that we've been putting together. On the left side, this is a snapshot. It's not the whole entire county because we couldn't fit it on one screen. But on the left side, you can see that we're mapping the EDI, which is those 5 developmental domains. The darker areas are census tracts where there's a higher percentage of children with at least one vulnerability in any of those 5 domains. Okay, so there's a greater concentration of children in those census tracts with a vulnerability in at least one of those domains. On the right side, there's the same thing, but presented for that Bruner vulnerability index. So those are the neighborhood risk factors, economic, social, and so on risk factors. And you can see, if you put them side by side, that there's certain areas which are darker on the left that are also darker on the right. So it's really interesting to be able to use that information because we can see where are there areas where there's great risk in terms of neighborhood risks, but also great risk in terms of developmental risk for children, and those are areas that we might target. What's really interesting is that there are areas, and we were talking about this as part of our team, is that there are areas where there's really great, a high number of neighborhood risks. Children are living in deep poverty. There's a high number of people in the household that don't speak English as their first language. That's one of the indicators, or are not working, or don't have a high school diploma. But those children are really outperforming and doing really well developmentally. So the conundrum then is, where do we identify those communities that are shining and that are showing resilience? And this is one way of figuring those questions out, or kind of going to the next step and figuring out where to go and learn from communities that are really resilient. Okay, so the takeaways from these findings, and we're going to have a chance to have questions at the end to talk more, is that our communities have many, many opportunities, but not all of our children have the same types of opportunities, and children are experiencing different kinds of risks and protective factors just where they live and every single day. That neighborhood vulnerability is associated with developmental vulnerability. And when we look at, I'm not presenting this today, but when we look at developmental vulnerability and how that relates to future school attendance, how that relates to whether they pass the 3rd grade reading, statewide reading exam in 3rd grade, these are all related. So the time is now, when they're very little, to find them and provide support and make sure they're living in neighborhoods and communities and getting the resources that they need. So you all have a really big job to do to make sure that those children that come into your office, to keep an eye out for that and make sure that they're getting the resources that they need at this time when you can make the most change. And so anyways, that's all I have to say. I'm going to transition now to introduce Christine. I'm happy to talk later and with any questions you have.
Hello, I'm Christine Delgado, and I am a faculty member in the Department of Psychology at UM. I am a developmental psychologist. I was actually trained here at UM, and I actually did my initial graduate student research in this building, so I've been around here for a while. One of my roles right now is the director of the Children's Registry and Information System. We call that CHRIS, and CHRIS is a whole project, but the big part of the project is a database. It's actually a database, and the database is used at Fiddlers. And hopefully most of you are familiar with Fiddlers, but for those of you that aren't, Fiddlers is the Florida Diagnostic Learning and Learning Resources System. It's a series of centers around the state where children would be referred if someone had a concern about them. So a parent has a concern, or a teacher or a pediatrician or healthcare professional has a concern about the development of a child, they would be referred to Fiddlers. Fiddlers uses CRIS, the database.
Tell them that Fiddlers is what comes after early steps.
Fiddlers is what comes after early steps, so yes, that's true. So Fiddlers is part B, early steps is part C. So early steps is first, and then Fiddlers does the preschoolers. So that would be the referral system for the preschoolers. CRIS is the database that's used by all the Fiddler centers to do case management, helps them, manage their cases and do service provision. It's also used by the Florida Department of Education to monitor the services that Fiddlers provides, to make sure that they're doing what they're doing as fast as they should be doing it. So CRIS is a database, but it's a database used at Fiddlers. And CRIS contains information on preschoolers. The main information that's useful to me, I'm the director of that project, the main information that's useful to me is the disability classification for the children in that system. So once Fiddlers screens, evaluates, makes eligibility determinations, and classifies children with developmental disabilities, that information is in that database. So that's useful to Fiddlers and it's useful to the Department of Education, and that's great, but it's also really useful if we can connect that data to other data systems to learn more about children. And that's the research, the main research that I do focuses on preschoolers with disabilities and what can we learn about them by integrating that data with other systems. So these are the systems that over the years I've integrated with the CRIS database. And some of them are local. The Head Start database and the IDEAS consortium that Rebecca just talked about are both Dade County, so those are local. But I have also linked the CRIS dataset, which is a statewide dataset, with other statewide datasets of public school records, birth certificate data, birth defect data. I'm actually in the process of doing that right now, so that's ongoing. But statewide birth defect registry information, and also statewide lead poisoning prevention, lead level rates for children as well. So I'll present some of the data from that right now. And we've also just finished a study looking at newborn hearing screening and linking newborn hearing screening data to, that was a partial state. So it's not the whole state, but it's more than Dade County on that one. So I'll talk to you about the lead and the newborn hearing screening in a little bit more detail. My research objectives, just real quick, I won't get into this for the sake of time, but I do, most of my research is on risk factors for disabilities. So looking at child factors like low birth weight, prematurity, birth defects, adult factors or parent factors like parents' age, parents' education, substance exposure, like alcohol and tobacco, things like that, and examining services, which Rebecca just talked about with IDEAS Consortium. So into more interesting. So some of the studies, one of the studies that I've done relates to lead. And lead we've known has been a toxin, we've known that since the 1970s. There's nothing new about that knowledge. And there are plenty of studies documenting that lead has negative impacts on cognitive development in children, especially with intelligence. We know there's cognitive impacts with lead. We also know there's academic impacts with lead. This is not new. What hasn't been studied is the relationship between lead and developmental disabilities and categorization of children with disabilities. We know individual skills are affected, but we didn't really know if it affected special education placement. So I partnered with the Florida Department of Health to get this lead data, and we integrated the CRIS records with the lead records. And we do that, we have identifiers, we have names. I have a child's name in one data set, I have their name in the other one, and I link those together based on their name, so I know when the child had the blood test done, this was what their lead level is, and I follow them a few years into the future, and I know what disability they ended up being classified with in this data set. So we did that, and what we found was that when we used the cutoff of 5 micrograms per deciliter, which is the new cutoff for high levels of lead, it's been reduced several times over the years. Most recently, 2012, it was actually 10, and they reduced it to 5 in and it's been as high as 40 or 50 in the past. So this cutoff for what we consider high lead is actually reduced a lot over the years. So it's at 5 now, and that's the cutoff that we use. And we found that even at that low cutoff, children with blood lead levels higher than or equal to or higher than 5 micrograms per deciliter had increased risk for developmental disabilities, especially intellectual disability and developmental delay. So that's not surprising. I mean, we hypothesized that. There's nothing new or shocking about that. But what it shows us is lead is still out there. It's still in our environment. It's still affecting our children in significant ways. And even though our risk ratios were relatively small, the risk ratio for intellectual disability was about 1.6. So they're not huge in an individual level. But when you magnify that by the number of children affected, the population level impact of lead is huge. I mean, it affects a lot of children, but it affects society as far as costs for managing special education care for those children. Special education is expensive compared to regular education. So as a society, we're dealing with this on a pretty broad scale. And I've got stats up there. There's over 500,000 children in the U.S. that have blood lead levels higher than 5. So it's an impact. The good news for Florida is that in this data set, there are very few children with blood lead levels greater than or equal to 10 micrograms per deciliter, which is great. Other states, I don't think, can claim that. So we've seen issues in Michigan and issues in New Jersey and things like that. So we're fortunate in Florida that our lead exposure is an issue, but it's not as big of an issue as it is in some other states. So this is just a way of saying, can we look at the environmental exposures that children have and their outcomes? One way to do that is by linking these data sets together. So that's what I've done. In a more recent series of studies that I've done looking at newborn hearing screening and disability outcomes. So linking the hearing test that a child got when they were born 3 to 4 years forward to their disability classification. And newborn hearing screening has been used for decades to screen for hearing impairment, which is a developmental disability. So it's been very successful in doing that, and it's done around the world actually now. There were some small studies that indicated that the auditory brainstem response test, which is one form of newborn hearing screening, indicates differences in children with autism. Okay, so those studies were done in older children, but they had ABRs that were different. Those studies were small. And it's hard to get large studies on children with autism, especially prospectively, right? So you'd have to follow a lot of children from the time they were born forward and wait for them to become identified with autism. So what you can do, though, is take data sets that exist. So this newborn hearing screening data set exists. Mednax, the company, Pediatrics, you might be familiar with them, provided that data to us. And I have the disability data, so we linked that together. And we were able to replicate the small studies that had been done indicating that newborns' ABR recordings, the waveforms, are different for children with autism compared to children that don't have autism. The differences are small. They're not enough to be predictive. We can't take an ABR and say, okay, this child's going to be autistic. It's not that good. But it's a tool that we can add to a toolbox to start doing early identification for children with autism. If we look at this a little bit deeper and understand it a little bit better. And we actually have a new grant right now that's just starting up to work on that, to try to figure out what about this we can harness a little bit better to maybe use it as a predictive tool. But that's very important. It's very important to try to identify these kids as early as possible. So this is one way to demonstrate that that's possible. The other interesting thing we found in this study was that we found the same finding that we found for autism with speech impairment. And that hadn't been found before, studied before. So we're taking children's hearing screen at birth and linking it to speech impairment, and found just as strong of a finding for that as we did for autism. Not sure why. We're still working on trying to understand the neurological mechanism for that and why those two would be tied together. It didn't come out for language impairment or developmental delay. So it's not that it's every disability, it's select disabilities, and these two happen to be the two that came out. So we're still thinking about that and trying to understand the connection there and the potential for that. But this it helps us. This sample had 370 children with autism and over 900 children with speech impairment. I mean, if you wanted to prospectively do that, you'd have to get newborn with the incidence rates for autism, you'd have to get newborn hearing screens on about 22,000 children and track them forward to end up with 370. So big data allows us to study things that will be very difficult to study in other ways, to get the sample sizes that we need. We lack detail, right? These big data sets don't always have the details we want. I don't know what type of speech impairment these children have. I don't know the nature of their issues when they're autistic, but I know they have that classification. We need to do big studies like this to find these connections, and then once we find these connections, do smaller studies with more detail to kind of follow them up. So Rebecca and I just presented to you a lot of research on what can be done, what has been done by integrating data sets together with the data sets that we've had and had access to. Scott and Robin are going to come up now and talk to you guys about other data sets that exist that can really enrich what we already know and we can add into these systems and these connections that we already have to really deepen our understanding of child's environment. So turn it over to Scott.
Yeah, I'm sorry. I skipped some stuff.
Okay. Hi, everybody. I'll ask you to bear with me because I have laryngitis.
Oh, no.
So my work is being done in the Department of Public Health Sciences along with the School of Architecture, and my primary appointment is in Public Health Sciences and secondary in Architecture. So this diagram here is sort of a theoretical model coming from the insights of architects and urban planners on what are the characteristics of the built or physical environment that are theorized to maximize well-being. And so we have had the privilege of working with architects, including Elizabeth Zyberg, the former dean of the School of Architecture, who developed the Congress for the New Urbanism over 20 years ago. And we've been able to do initially studies in the field, and then we realized that big data would sort of speed our progress in this area of being able to generalize about impacts of the built environment. So our early work was in Little Havana. We were looking at two different studies, one of which was conduct grades in Miami-Dade public school children, and we were able to identify in the slide on the left that contrary to popular opinion, children who resided on blocks in which there was mixed-use development, that is, there were stores and parks and other destinations for walking within proximity to homes, had better child conduct outcomes. Interestingly, we also looked at in the same neighborhood a cohort of 300 Hispanic elders in whom we were able to identify greater levels of social support as well as mental and physical functioning in elders who had more positive front entrance features in the front of their buildings, including porches and stoops, which were theorized to maximize opportunities for visual and social contacts. So these two studies came out of New Urbanism and the work of Jane Jacobs, an urban social critic from the 1960s. So building on these initial two studies, our team, going the wrong way, of course, we began to look at other characteristics that were theorized to be related to better outcomes. So in one study, we looked at 400 new Cuban immigrants, ages 30 to 45, at risk for weight gain and development of the metabolic syndrome. And we found that this is, of course, a map of Miami-Dade County, and we use distance to the urban growth boundary, which is up on the western edge, as a proxy for urban or suburban sprawl. So folks living in the western part and southern parts of the county tend to live in areas where there is very car-dependent development, that very few destinations for walking, such as stores near homes. And we actually found that 400 new Cuban immigrants within 40 days of arrival had greater opportunities for walking the further that they got to the coast, in which there was more compact mixed-use development. And I'm wrapping up here because we're short on time. But we also subsequently have been looking in Medicare beneficiaries at the relationship of block-level greenness from NASA satellite imagery to multiple chronic health conditions. And we have identified that in Medicare beneficiaries, approximately 250,000, we have identified that blocks in which there are higher levels of greenness have fewer chronic conditions, and this is approximately equivalent to a reduction in biomedical aging of the population by 3 years. And so we to date have published on the relationship of greenness to cardiometabolic conditions, including reductions in diabetes, hypertension, and hyperlipidemia. And this year we published on the linkage to heart disease in the Journal of the American Heart Association, as well as depression in the British Journal of Psychiatry. So we're excited about the possibility of using some of these same metrics in relation to child development outcomes with Rebecca and colleagues. And now I'll hand it over to Robin.
So I'm going to be brief because I know we want to leave time for questions. But our work focuses on the role of housing and access to safe, secure, and stable housing and overall outcomes for families. So some people are surprised to learn that Miami is the least affordable city in the nation, right? So people say, well, Miami is not as expensive as New York or San Francisco or Chicago, and that's true. But in fact, our affordability gap is the highest. So that's the difference between the cost of housing and what people earn, right? The average median income. So you can see in this chart, this is actually showing severe cost burden. Severe cost burden is when people pay 50% or more of their income on housing. So you can see that Miami is well above many other metropolitan areas in the country. So part of what my team did at the Office of Civic and Community Engagement is created an online suite of mapping tools to understand the data around housing access, housing affordability, and try to create strategies for promoting equitable community development and more access to affordable housing. So our Miami Housing Solutions Lab does that. Like Rebecca, we've worked very closely with the UM Center for Computational Science so that we can take big data, GIS code it, and map it in a way that tells a story that spreadsheets and reports can't tell. So this is a map that shows cost burden across Miami-Dade County. This is from our project called MAP, or the Miami Affordability Project. So any area that you see that is red, those red census tracts, means that 75 to 100% of those households are cost burdened. Orange is 50% to 75%. So you can see that most of Miami-Dade County has significant cost burden. We then mapped where there is public and assisted housing. So the magenta dots are public housing, the purple dots are assisted. So that means there's some kind of federal, state, or local subsidy that went into building that housing. So what you can see just from this one screenshot is that there's a lot of concentration of affordable housing in the urban core, but as you go further south and further west in the county, there's a lot of need and not a lot of access. So we have about 200 different data filters on this mapping tool. So there's information related specifically to housing, so what kind of housing is available. This is all overlaid with census data from the American Community Survey. So every census detail that's part of the American Community Survey is available by clicking on any census tract in the county. We also looked at Section 8 housing. So this is what are called housing choice vouchers, where people can get access to an affordable apartment in a building that is market rate. And then we also included information on historic sites that could potentially be preserved as a way to create housing affordability. So this is just a sample of the kind of data that you would get if you click on any census tract. We also created a housing policy toolkit that looks at best practices in housing policy across the country, how they could be applied locally within the Miami-Dade County legislative landscape, and then a neighborhood by neighborhood drill down on which of these policies would be most appropriate. So for example, in Overtown, there's a lot of vacant land, so looking at creating something like a community land trust might make sense there, where in Little Havana, there's a lot of what's referred to as naturally occurring affordable housing. This is market rate housing that happens to be affordable, usually because it's older. So again, it's neighborhood by neighborhood strategies. Oops. We're also looking at the relationship between affordable housing and urban resilience, so looking at flood risk. Obviously, sea level rise and storm surge are important issues that we all face, but we want to look at how those resilience factors impact our affordable housing stock. So we're working very closely with the county's Department of Public Housing on addressing some adaptation and mitigation features for affordable housing. And then the latest project that we've just launched is called Land, or Land Access for Neighborhood Development. This looks at all of the vacant or underutilized land across the entire county that is either owned by a public entity or a civic institution or an anchor institution like a university or a hospital. And quickly what we found is there are over 500 million square feet of vacant or underutilized land across the county. That's an incredible opportunity for policymakers, researchers, grassroots advocacy groups to think strategically about how to effectively use this land in order to promote equity, sustainability, and solutions that will enable everyone to have access to safe, secure, and affordable housing. So I just want to wrap up really quickly by saying that much of our work together as a ULING team is really focused on how we can effectively utilize big data to address questions that we wouldn't be able to address if we didn't have access to these multiple sets of data that cross sectors. So it's bringing different sectors together in order to address common needs. We know from our work and for other studies that place matters, right? It's a common phrase now to say your zip code matters as much as your genetic code. And so we want to pool all this data together, map it, understand it spatially, but then also disaggregate it to understand what are all the various factors that contribute to early childhood success, school readiness, and overall positive outcomes for children and families across the county. So thank you.
Wait, stay where you are. Introduce yourself so they know who you are.
Oh, okay.
Come back up.
I'm Robin Backen. I'm the Assistant Provost for Civic and Community Engagements, and I also teach urban and environmental history in the history department.
So you're a historian by training.
I'm a historian by training.
Thank you all. So for the people who came in late, I'm just going to say a couple words about how this all fits together, and then we'll have a few minutes for questions. At Nationwide Children's Hospital in Columbus, Ohio, the way the hospital and all the physicians and all the mental health professionals are paid is a per member per month global budget. So that means that the hospital corporation gets a lump sum to take care of the 300,000 people who live around the hospital, children. So imagine for a second that that's the way Jackson got paid. That we actually were responsible for all the children who lived in, say, a 5-mile radius around our hospital. And we all would get paid based on our contribution to improving the health of those folks. What would we start doing differently? If we have a global budget, that means going into the ICU and using the emergency department are bad for our bottom line. Right now, they're sort of good. When the hospital's empty, our people in charge of the hospital say we're in trouble because our hospital's empty, we're not bringing in dollars. It flips the whole equation. So now you start saying we need to make sure that people are healthy and don't come to the hospital. And where they've gone so far in Nationwide Hospital is now they're working with, because we know that stable housing and a good job reduces the chances you'll have an asthma exacerbation. Right? So now they're working with community partners to improve the health of people in their neighborhoods. So a lot of the idea this morning was to introduce you to the scholars, the people who are studying neighborhoods and place and trying to understand things. I'm going to ask the first question, but then we'll ask you guys. So if I watch the data that you put up there, I think about what you said, Scott, and that is the closer you are to the urban core, and the more you have walkability, the more you have neighborhoods that seem to promote health, that improves health. But I think about some of the data that Rob and Rebecca presented about poverty, and seemed like made things worse. So how do we figure out how those things interact?
So I can speak to that. Sorry. So I sound like the informant in the White House. Sorry to get political. So to answer Jeff's question, we actually did look at the interaction of neighborhood income with the impacts of greenness on health. And we actually showed that the association of greenness to different health outcomes, they were approximately 50% stronger in lower income neighborhoods where the median household income was $31,000 per year. So on the basis of those findings, we were able to go to Robert Wood Johnson's Evidence for Action program and ask for funding so we could do follow-up work looking at the impacts of ongoing greening interventions, including tree planting, where over 200,000 trees have been planted in Miami-Dade County with focus on lower income communities.
Other questions? Yes.
First of all, I want to congratulate you on this wonderful presentation and the work you're doing. But I do have a question. I didn't hear, or have you thought about looking at parent impact on early childhood success? Or do you have any data regarding that? Or?
So, because we're taping, so I'm going to repeat the question. So the question is, are we using any data on parent and child interaction as part of our data set? And I'm going to think Rebecca is probably the one who can best answer that, so I'm going to have her jump up here and answer.
So we know that that's probably the most proximal, right, to children's development, especially their social emotional development. But when we have these big, large data sets, many of them coming from census tract indicators that are collected at the UN. Am I not talking? Oh, there we go. Okay, sorry. Did you all hear that? Okay, so we know that those micro interactions are probably the most influential, right, on children's early development. But the data that we're talking about today really are at the census tract level. These are indicators that have come from community surveys, U.S. Census, many of them, or other macro level variables. So there aren't really many of those type of measurements in these data sets. But there is research going on. You know, we are doing research. There's several research studies in the Department of Psychology that are looking at that in a different set of studies. But it would be interesting to be able to integrate some of that information with our data sets for sure. And we have some information about family engagement in schools that also could be integrated. But I agree, it's really important.
Other questions? Yes, Dr. Friedman.
And thank you for that information. And along those same lines, do you have outcome data about those infants and toddlers that had all of those vulnerabilities that put them more at risk for when they're older, as school success or graduation from high school or criminality?
Hold on a second. So you may have guessed that Dr. Friedman is an adolescent medicine doctor. So he's asking about the connections between those early childhood indicators and the later indicators, and if you could say a word or two about that.
These kids are now in 5th and 6th grade. So we have a grant out to request data, the school level data for those children now. And once we get permission to link the data, then we'll know the answer to that question. But other studies have indicated that there's definitely a relationship between the two, and especially in terms of adult outcomes as well, earnings and college attainment and high school graduation.
Perhaps one of the most famous studies is the Perry preschool study that looked at 2 years of high-quality preschool and had follow-up at age 40. And the chance that someone lived in poverty, owned a home, was in trouble with the criminal justice system. And it was a randomized study, and that there was a waitlist control. It showed a dramatic improvement from kids who had 2 years of high-quality early childhood education, such as at the Debbie School. The last question I'm going to ask Dr. Backen, if we say at Jackson, as a group of professionals who are responsible for all the children living in Overtown, is there some way that the housing data you have might help us, or is it such at a census level that it's not fine-tuned enough to help us figure out how to improve the health of that population?
So all of the data that we have with regard to housing is publicly accessible and available data. So we do have census tract level data, but we also have data at the parcel level, not for the information about a particular family, but for ownership, rent, that kind of thing. But within public and assisted housing projects, I showed you those purple and magenta dots. You could click on any of those dots and find out the specificity of the population that that housing project is targeted to. So for example, if it's targeted to families, you would know that data. If it's targeted to a particular income level, you would know that data. So at least within a housing project, you would know the specificity of the population that is living in that project. There's also a project that we're working on in collaboration with the Department of Public Housing of the county, which is to think about co-locating early childhood centers in public and affordable housing projects. So that's part of a new HUD program at the federal level that they're going to be implementing over the next year to 5 years at the local level. Again, just thinking about the issue of attendance that Rebecca mentioned and higher levels of success for children when there's obviously positive attendance at school and early childhood development centers. So that's another link between early childhood development issues and access to affordable housing.
Please join me in thanking our panel for their presentation.